Right. So let's start with apical HCM. So apical HCM refers to when the apex or the tip of the heart is affected with the thickening. And this is a condition which typically is not associated with obstruction in the LV outflow tract. And for many years, this was advertised as a condition that's benign or really kind of a curiosity, but not of much consequence. But it is important to note that a subset of patients with apical HCM will develop this apical aneurysm, or this little outpouching in the tip of the heart where things were thick that becomes thin and can become full of scar. It's important to recognize this, and to diagnose this, we frequently need a special echocardiogram with contrast. So those of my apical HCM patients that I have that I insist that you come into the downtown hospital and get an IV to look for this, I apologize for the inconvenience, but we can miss these in the regular echocardiogram if we don't use echo contrast. We can also look for it with a cardiac MRI. And the reason it's important to look for this is because that aneurysm that's full of scar serves as a nidus or a source for arrhythmia formation. So ventricular arrhythmias or a short circuit can happen around that scar and tip patients into ventricular tachycardia. So most often when we see these aneurysms, we're going to recommend that you get a defibrillator placed. The other important thing to think about is that this little bubble here that's isolated from the heart is not having normal flow or motion of the blood that's in there. And if that blood sits there and it stagnates, it can clot. If it clots, it can break loose and go to your brain and cause strokes. So if we see these aneurysms, we will frequently have to have a discussion about whether or not to start anticoagulation. It's also important to note, and we've made some important observations that hopefully will be published soon, that the size and quality of that aneurysm matter. So smaller aneurysms with less scars have lower risk of arrhythmia and clot formation than larger aneurysms with more scar. So the discussion may not be binary, it may be a little more nuanced and take into account your age, the size of the aneurysm, and the scar when we make these decisions. So moving on, we just spent about 45 minutes talking about obstruction and how to treat it. We have medications, we have septal reduction therapies, but a third of patients will not obstruct. So you may have a thick septum or a thick apex and have no interaction. There's no tango going on, as Dr. Gami said, where the mitral valve is not obstructing here. So there's no role for septal reduction therapies in these cases. There's a limited role for medications like beta blockers and calcium blockers. They may improve symptoms in some, but not always. There's likely no role, and at least it's definitely not FDA approved, for mavacamten and cardiac myosin inhibitors. Like Dr. Carrick mentioned, the trial for mavacamten did not show symptomatic improvement. Interestingly, it did show improvement in markers of cardiac stress, like blood markers. So there may be more investigation going on there, but as of right now, there's no role for these medications. So when we treat non-obstructive HCM, I think we can take a step back and break it down into two general categories, like what are the symptoms we're treating. One symptom complex or group is angina or chest pain, which we think is due to a supply and demand mismatch where that thick muscle needs more oxygen than it's getting, and if it doesn't get the adequate supply of oxygen, you start having chest pain or angina. It is important to make sure that there's no coronary disease, which is a common condition, especially as we get older, if we have other risk factors like cholesterol or hypertension. So before we conclude that your chest pain is from HCM, we will frequently want to make sure there's no coronary disease. We'll do that frequently with a CT scan, but in some cases we may have to resort to a catheterization or angiography. When we exclude coronary disease, then treatment, the main treatment I like to use is calcium blockers like verapamil. There's lots of studies showing that perfusion in these areas is abnormal, and that using calcium blockers like verapamil can help improve the perfusion to these areas. And there's other drugs like ranolazine that act to decrease the amount of oxygen that heart's consuming and improve the efficiency of the heart and therefore decrease pain or relieve symptoms. The other group of symptoms are symptoms of heart failure. And heart failure is kind of an entity or a group. When I mention this, patients tend to get scared, but it's in a little bit in a way like a cough. You can have a cough, and that can come from many different reasons, but the end result is that you cough. So regardless of what causes your heart failure, the symptoms come from either increased pressures in the heart or congestion, those pressures back up, or the inability of the heart to get oxygen to your tissues when those tissues need it. The symptoms therefore manifest as congestion or swelling or fluid retention, and with shortness of breath, particularly with activity when your body needs more oxygen and you're unable to get that oxygen to the tissues. So in these patients, we'll frequently need some more specialized testing. You may need catheterizations to measure pressures in the heart, or a right heart catheterization, and we'll frequently perform functional testing to go beyond what you're reporting as your activity level to a more objective measurement of how much you can do compared to somebody your age, which helps us kind of figure out just how limited you are. Treatment strategies will then really be broken down into two main categories. We've talked about this ejection fraction, or EF, and it makes a difference whether that EF is reduced or preserved. And what that EF is if we start with a full heart, what percentage of the blood in the heart is ejected with each heartbeat, ejection fraction. So in this case, if this heart starts with 100 milliliters, and at the end of contraction, we're left with 50, that's 50 went out, then 50 out of 100 would mean an EF of 50%. Okay, so that's the concept of EF, is how much I'm pumping out with each heartbeat. A normal EF is in the 55 to 70% range, and our HCM population tends to live on the higher side of that range. So when thinking about heart failure and treating it, we're going to start with that echocardiogram, and we're going to look at that EF. If that EF is lower than 50%, we're going to call that reduced ejection fraction heart failure, or HFrEF. And if that ejection fraction is 55% and greater, and you still have congestion and symptoms, we're going to call that preserved ejection fraction heart failure, or HFpEF, which sounds like huffing and puffing, or HFpEF. And so starting with reduced ejection fraction, when that EF falls below 50%, you may hear other terms like end-stage HCM or burnt-out HCM. And when we see this, we get aggressive with what we call the 4 pillars of guideline-directed medical therapy. These are families or classes of medications aimed at preventing the heart from continuing to get worse and trying to rescue some of that heart function. We will also identify you as a patient as being at higher risk for arrhythmias, so there should be a defibrillator implanted in this case. And in certain cases where conduction in the heart is abnormal, and instead of beating in this fashion, you have this dysynchronous beating, we may be able to pace in a way that synchronizes the ventricle again to make it more efficient. And then, of course, if you are congested, swollen, we may use diuretics to relieve that congestion and make you feel better. Flipping to preserved ejection fraction, you may also hear the term restrictive cardiomyopathy, or RCM. And this population of patients really, unfortunately, were more limited in the tools we have. There does seem to be a role for these medications called SGLT2 inhibitors, which were originally diabetes pills, Jardiance being the one we frequently work with. There may be some role for mineralocorticoid inhibitors like spironolactone. We will use diuretics again as needed, so if you're swollen, short of breath, diuretics help decrease that swelling. And then, as we mentioned before, cardiac myosin inhibitors are being investigated. Unfortunately, that preliminary data for mavacamten in the Odyssey trial was not what we hoped for, but there may be some hope still. We'll see what the aficamten trial shows. And like I mentioned, despite patients not feeling better, there were paradoxically a lot of markers of stress that did look better in that trial. And there are other drugs being investigated. There's one that just recently got published, which modulates cardiac metabolism, helps the heart use more glucose, makes it more efficient, and in doing so seems to make patients feel better. So there are more drugs coming down the pipeline. I'm not getting into gene therapy. The gene therapies are another kind of area where we're hoping to identify and be able to correct some of these gene abnormalities. That field is still very early on. There's some very preliminary data that does look promising, but I think we still need to work on that a lot more to identify which are the right patients to get it, what the right gene therapies are, how to deliver them, what the long-term impact on that is. Bottom line here, it's an area of investigation. So regardless of whether function is preserved or reduced, as we mentioned earlier, there does seem to be a role for these new GLP-1 weight loss agents, which were diabetes pills. They're also, injections. They were also medications that seem to make patients lose weight. But we're also noticing that in heart failure populations, these weight loss agents are helping in decreasing the incidence of heart failure events. So for those of you who have a BMI of 30 or greater that have symptoms of heart failure, we have been getting more aggressive at prescribing these, and Sarah Riley, who was around, has been really spearheading these prescription programs for you guys. And then lastly, regardless of whether your heart function is low or high, in patients that are not responding to medical therapy and that are severely limited or having hospital admissions from heart failure, there is a role then for cardiac transplantation. And we work together closely with our heart transplant team, and HCM patients in general as a population have favorable outcomes with heart transplant. So that is always something we have kind of in the back of our minds. So thank you. That concludes the non-obstructive part. And again, the symposium has been sponsored by Bristol Myers Squibb and in collaboration with DHCMA.